Great. Good afternoon, everybody. My name is Sharon Rounds, and I'm happy to be presenting today the Advanced Rhode Island CTR Clinical and Translational Research Seminar Series. Today, we have two of our very talented pilot project awardees presenting, both from the Department of Neurology at Brown. Our first speaker is Saud Alhusaini. He's an assistant professor of neurology at Brown. He did his training at Trinity College in Dublin and the Royal College of Surgeons in Ireland. He then did neurology residency at McGill, and then fellowships at Yale and also at Stanford University Medical Center. He'll be talking today about his project on the application of imaging genomics in common movement disorders. So take it away, and thank you so much for being able to join us today to give this seminar, both of you.
Thank you, Dr. Rounds. Excellent. So I will go ahead and just talk to you about the concept of imaging genomics with hopefully a focus on movement disorders. So first of all, I have no disclosures. And this is the outline of my talk. We'll start with a definition and overview of the imaging genomics field. I will hopefully quickly run through some of its initial application, mostly in healthy controls and some brain-related disorders. And hopefully we'll get the time to spend some time to talk about imaging genomics and movement disorder. And I will end up with future directions if the time allows. So first of all, I guess the question is, what do I mean by imaging genomics? This is a very relatively new and evolving field that integrates imaging and individual level genetic data. If we focus on brain imaging specifically, we can label it as neuroimaging genomics. And it has so far been applied to investigate the genetic risk factors that are responsible for the variation in brain phenotypes, and also study the association between genetic risk factors and brain imaging phenotypes of brain-related conditions. So the goal is really to see if this field will help us understand the genetic and the neurobiological mechanisms of underlying neurological and psychiatric conditions. So some of its initial application was really looking at the heritability of brain imaging phenotypes, really focusing on how much genetics influence brain phenotype and, from an imaging point of view. So this is an example of a study that was published in 2013, looked at the heritability of subcortical brain regions, which are highlighted here on the image, specifically 8 structures. It was a twin-based study design. So this study included 176 monozygotic twins, as well as 88 dizygotic twins. The age range was between 11 and 56. And through this study design, the authors were able to demonstrate that the subcortical structure volumes is actually very highly heritable, but the highest heritability was noted for the thalamus, as well as the caudate nucleus. And then some of the other structures had more of a medium heritability effect. For example, the nucleus accumbens was showing basically up to 44% heritability. So this is obviously intriguing because we can definitely see that there is a genetic component to brain imaging phenotypes. And this was a follow-up study that included a large sample of healthy individuals looking at the shape of these structures. So earlier I showed was really the volume, but here focusing on the shape of these brain regions. And again, the heritability was relatively medium effect, ranging from 32 to 53%. The field, though, progressed and moved from measuring heritability to actually trying to identify genetic risk variants that are responsible for brain imaging phenotype. So this is an example of quite an impressive study in terms of sample size. So the authors included more than 31,000 individuals from different cohorts, a total of 60 participating centers, and they ran a genome-wide association study to look for common variants that actually can explain imaging phenotypes. So the phenotype of interest was that the cerebral cortex, subregional or subregions. So we can see here up to 34 brain or cerebral cortex regions were studied, focusing on the cortical thickness as well as the surface area of these regions. And collectively, a total of 241 genome-wide significant loci appeared to be associated with surface area of these brain regions. And then 66 loci were actually associated with cortical thickness. So you can see they span the entire genome and from chromosome 1 to chromosome 22. And then later on, a recent study looked at the genetic risk variants that influence intracranial volume as well as subcortical brain regions. Again, a very impressive sample size here of more than 74,000 individuals. And applying this method, which is the genome-wide association study design, a total of 254 independent loci were associated with brain volumes. And these specific common variants appear to be responsible for up to 35% of the phenotypic variation in this cohort. So it's clearly, we can say that there is a genetic component to the imaging phenotypes. And the question is, how do we actually apply this in brain-related conditions, be it psychiatric or neurological conditions? So from my interest, obviously, I'm a neurologist and focusing on neurological conditions. I want to give an example of neuroimaging genomics that was applied in neurodegenerative disorders, specifically Alzheimer's disease. So this study looked at the association between Alzheimer's disease risk variants and amyloid deposition using amyloid PET scans. So it's a well-designed study that included 322 healthy controls, 496 individuals with mild cognitive impairment, and 159 patients with Alzheimer's disease dementia. So the authors focused on known genes that are associated with Alzheimer's disease. So they looked at 20 genes. And then within these genes, the focus was on common variants that are present in these genes based on Alzheimer's disease genome-wide association studies. What was interesting is when they specifically looked at the APOE gene, which hopefully we'll hear about more from Dr. Sarangi later, there is a strong association with brain amyloid. This risk basically gene is associated with high risk for Alzheimer's disease, and it's estimated to, if you carry the risk alleles, you're probably close to 8 or 10 times higher risk for Alzheimer's disease. So when they looked at this specific gene and risk variants within these genes, specifically the APOE4, it was clearly associated with amyloid deposition. So here, the data is pulled together, so you can see strong association, but also dividing the groups into 3 groups. The association is very evident, including individuals who are cognitively normal. And then when they looked at the other genes and risk variants within the other genes, you can see some of them also show a clear association with amyloid deposition despite controlling for the APOE4 gene. So how do we apply this in Parkinson's disease? And I'm going to talk to you about studies that I've done myself. Obviously, it's a very evolving field with many research groups also interested in the same topic. So one of the work I've done is really focusing on the alpha-synuclein gene. So as you all probably know, this gene is or encodes for the protein alpha-synuclein. And if there are rare genetic variants that are responsible for autosomal dominant forms of Parkinson's disease. So these include missense or copy number variants. But familial form of Parkinson's disease is very rare. And what we actually see in our clinics are more sporadic cases, or what we call common forms of Parkinson's disease. So the question, alpha-synuclein gene, does it carry specific variants that are more common in the general population, not these rare variants that are responsible for autosomal dominant Parkinson's disease? The answer is yes, and we know that common variants can also be seen in other synucleinopathies, including dementia with Lewy body and REM sleep behavior disorder. And this is an example of a study that specifically looked at the common variants in the alpha-synuclein gene using a sporadic Parkinson's disease sample. So they applied a very well-designed study where they compared patients with Parkinson's disease to those who are healthy, and they identified a very significant variant within the alpha-synuclein that was strongly associated with Parkinson's disease, and then rerun the analysis controlling for these top variants. And after removing the effect of this top variants, there was a second one that also jumped out and seemed to be very associated with Parkinson's disease. And they rerun the analysis again for the third time, accounting for the top two, and still a third one seemed to be very associated with Parkinson's disease. So the authors concluded that there is at least 3 independent genetic variants that are common in the general population, but are clearly linked to Parkinson's disease. So the work I've done is really looking at these specific variants and how they are linked to imaging phenotypes of Parkinson's disease, specifically the dopamine transporter scan. So I used 381 patients with de novo Parkinson's disease from the Parkinson Progression Initiative, Parkinson Progression Markers Initiative, or PPMI. So these are newly diagnosed patients who have not received any treatments yet. All of these individuals have undergone genotyping as well as brain imaging. So we were able to extract these 3 specific genetic variants that I mentioned earlier. And we were able to calculate the genetic risk score based on the effect size of each of these variants, as well as how many individual carries, or how many of these risk variants they carry. Our imaging phenotype was the dopamine transporter scan, which looks at the integrity of the nigrostriatal pathway, which I highlight here. The normal imaging or the normal finding would look like this, and it really assessed the presynaptic uptake of the radioligand, and just basically indicates if there is reduced uptake, it will reflect probably neurodegeneration happening within the nigrostriatal pathway. So we looked at baseline imaging as well as 24-month follow-up findings. Our outcome was the mean caudate and putamen uptake, which are part of the basal ganglia and the striatum. And we were also interested in the asymmetry between the left and right. And this is clinically relevant because most of these patients often present with one side affected. And when we look at their DAT scan, we see reduced uptake in one side more than the other, or the contralateral side basically more affected. So this is an example of a normal DAT scan, and this is a patient with Parkinson's disease. You can clearly see the reduced uptake, and you may appreciate some asymmetry as well. In this specific individual, there was a reduced uptake on the left striatum compared to the, well, I guess bilateral reduction, but clearly asymmetrically worse on the left side. So what we found is when we look at the mean uptake, we really didn't see any strong association. However, when we measured this asymmetry index, or the difference between the left and right, we saw a strong association with the genetic risk score for the alpha-synuclein, and this seemed to be driven mostly by the top 2 variants within the alpha-synuclein gene that I showed earlier. So our conclusion was that a more lateralized putamen dominant degeneration in early Parkinson's disease may represent a viable endophenotype in carriers of the alpha-synuclein gene. So it's quite interesting because when we actually reviewed the literature, especially looking at clinical data that looked more into these variants, it seems to be that PD patients or Parkinson's disease patients who carry these risk variants seem to have a specific clinical phenotype, so they tend to have more of a tremor predominant Parkinson's disease, and their disease progression tend to be slower. So there may be more to these common variants that may be associated with a specific clinical subtype of Parkinson's disease. Next, I went to explore more the polygenic risk score. So I want to kind of give an idea of what does this mean. So you all know probably that genome-wide association studies have really advanced our understanding of the genetic architecture of complex diseases as well as complex traits. So it has been widely applied and demonstrated clearly that complex conditions and disorders are linked to common genetic variants. So an example that I give here is Parkinson's disease. So this is a study that applied the genome-wide association design to compare a large number of patients with Parkinson's disease to healthy controls. And you can see from this what we call Manhattan plot. All these common variants are plotted across the entire genome from chromosome 1 to chromosome 22. And then all these boxes highlight variants that are clearly associated with Parkinson's disease. So really the common Parkinson's disease forms that we see in our clinics. You can appreciate that some of these variants are within candidate genes, like the GBA, for example, the alpha-synuclein gene that I mentioned earlier, and then LRRK2. So these are genes associated with familial forms or rare genetic forms of Parkinson's disease. However, many of the other variants are really, spread throughout the genome or with no clear link to causal genes or candidate genes. And many of them are present in coding and non-coding region of the genome. So the question is, how are they really linked to the pathophysiological processes of Parkinson's disease? So here, the polygenic risk score may help and hopefully address this gap. So the idea is that we could potentially calculate a score that aggregates the effects of all of these risk variants across the entire genome into a single measure that at least we can use, for research and clinical application. So an individual who has a high, for example, genetic risk score for Parkinson's disease would be at high risk for Parkinson's disease in later life. And similarly, or the opposite, someone who has a low PRS score will have a very low risk for future Parkinson's disease, just an example. And this PRS concept or polygenic risk score concept has been applied in many ways, including assessing the genetic susceptibility for a polygenic disease, help stratify patients for clinical trials and clinical applications, and also help identify disease-related phenotypes and biomarkers, which I'm interested in that. So when we looked at Parkinson's disease polygenic risk score and its association with brain imaging phenotype, we used a cohort called the UK Biobank cohort. This is a population-based study across the UK, or many centers across the UK. We extracted a total of 32,556 healthy controls and 1,821 asymptomatic first-degree relatives of patients. We labeled them as proxy cases. We didn't include Parkinson's disease patients here because we know their imaging could be altered by the disease itself. And our imaging phenotype was intracranial volume, subcortical structures, and brainstem volumes as well. So these are specific regions that are involved in Parkinson's disease. We managed to calculate a genome-wide Parkinson's disease polygenic risk score, and then we were able to validate that Parkinson's disease patients have a high polygenic risk score for PD when we compare them to the healthy controls as well as their relatives. What was also interesting is the first-degree relatives of patients also had a higher polygenic risk score for Parkinson's disease compared to healthy controls, demonstrating that they are at high genetic risk for Parkinson's disease. So next, we looked at the association between Parkinson's disease polygenic risk score and the brain phenotypes of interest. So what we were able to find is a higher PRS for Parkinson's disease was associated with larger intracranial volume. And then after adjusting for intracranial volume, we also saw a positive association between Parkinson's disease risk score and several brain regions as well. So an example is here where we divided the healthy controls into quantiles based on the PRS. So Q1 will have a very low Parkinson's disease PRS, and Q5 would have a very high Parkinson's disease polygenic risk score. This is the proxy cases or the first degree relatives. So you can appreciate those who have a high Parkinson's disease polygenic risk score had actually larger volumes. And the first degree relatives almost fell or fall within that range of high intracranial volume. So our conclusion was increased genetic risk for Parkinson's disease is actually associated with a larger intracranial volume and larger subcortical brain regions, as well as brainstem. This could potentially reflect early structural changes related to Parkinson's disease susceptibility, which was a bit surprising because, as you know, Parkinson is a neurodegenerative disorder, and most imaging would probably show more atrophy in these specific regions. But when we actually reviewed the literature, we found that studies of patients on the prodromal stage or very early Parkinson's disease, they actually tend to have larger brain volumes. And then with the progression of the disease, atrophy will set in, and then with the advancement of the condition, you would notice the atrophy that we would usually expect. And this is just showing the other brain regions that we looked at. So that's kind of, the study that I've done so far. And in terms of what I'm doing now and the project that was, I received the funding for from Advanced CTR, was looking at the association between essential tremor, genetic risk variants, and cerebellar phenotype. So essential tremor is another movement disorder, somehow linked to Parkinson's disease, because sometimes it's harder to differentiate from Parkinson's disease. At some stages was actually thought to be a benign condition, but now we know it's a chronic progressive neurological disease. It's a disease of older people, so more than 5% of individuals over the age of 65 could develop the condition. And from clinical features, most patients will have tremor in their hands that can be progressive over time and very disabling, but they can also get tremor in their neck, voice, and jaw. Later in the disease course, some patients may also develop gait disturbance and imbalance, and there are non-motor symptoms that are associated with essential tremor, including a specific cognitive profile or cognitive decline, as well as depression and anxiety. Throughout our learning of essential tremor, even in early training in medicine, it was always thought to be heritable, and there is a genetic component to it. Most patients actually do report a history of essential tremor in a first-degree relative, and early work has demonstrated genetic risk variants within specific genes in large volumes with multiple affected individuals. There is a recent genome-wide association study, so it's the same design that I showed earlier, in patients with essential tremor, and this revealed 11 genome-wide significant loci associated with essential tremor. And you may ask why cerebellar phenotype specifically. This is based on post-mortem studies that demonstrated neuropathological changes within the cerebellum, mostly affecting the Purkinje cells. So the study design, we're actively recruiting and analyzing the data. So the first objective is really to identify reliable cerebellar phenotype. We're applying a multimodal imaging method using MRI as well as EEG. The MRI will include structural imaging, diffusion-weighted images, as well as resting state functional MRI. And then the EEG, we are hoping to capture cerebral oscillations using EEG. Once we hopefully identify reliable cerebellar phenotypes, we want to see if they're associated with the genetic variants of essential tremor that I showed earlier. So we probably will either do a polygenic risk score approach versus assess each of these single variants and see if the genotype would actually affect or be associated with the cerebellar phenotypes of interest. So in summary, I guess you can clearly see that imaging genomics is still a new field and rapidly expanding and evolving. I believe it holds a great promise in helping us understand complex conditions such as neurodegenerative disorders, Parkinson's disease, and others. Multi-sites, I believe, is going to be needed still to kind of advance the field. However, we know now there are many consortia that are forming, trying to gather data together and run meta-analysis. So hopefully the future is very promising. I want to end by acknowledging key people in my journey. So specifically Dr. Joseph Friedman, who's the division head of the movement disorder at Brown, Dr. Karen Fury, who's our department head, and then two of my collaborators and mentors, Wael Assad, who's helping us with the EEG interpretation and analysis, and Dr. Alpert, who's helping us with the genetic study analysis. And I will take any questions.
Super. Thank you very much. Let's see. I don't see any questions in the chat, but folks feel free to enter them. I have a couple of probably naive questions. It appears that Parkinson's disease is in fact a heterogeneous condition. Am I correct in that understanding? So my question is whether these imaging or genetic approaches can be used to characterize different subtypes of Parkinson's disease, and whether that has therapeutic or prognostic implications.
Yeah, a very good question. So you are definitely right. It's a very heterogeneous condition. Even clinically, patients can present differently. So we have tremor predominant subtype. We have what we call rigid akinetic subtype with no tremor and more like a gait issue and gait slowing. I do believe hopefully imaging can help us in kind of defining subclinical traits that could be associated with each of these clinical subtypes. The hope is incorporating hopefully genetics and imaging, we can narrow down the underlying processes and specifically focus on molecular pathways that may be linked to these subtypes of the condition, with the hope that eventually we'll find a disease-modifying therapy based on these molecular pathways that we hope to identify.
Is the same true for essential tremor?
Well, sadly, essential tremor hasn't received a lot of attention, and not much work has been done compared to Parkinson's disease. So I would definitely say from a clinical phenotype, it's also another heterogeneous condition. There is a lot of overlap with Parkinson's disease, and that's what sometimes could be very challenging to diagnose, even from a clinical point of view. So yes, definitely the same.
Well, very interesting, and we'll look forward to seeing more of this as your work progresses. And thank you very, very much.
Thank you.
Our next speaker is also an Advanced Rhode Island CTR Pilot Project awardee. Sasmit Sarangi is a neuro-oncologist at Brown University Health and based at Rhode Island Hospital, an assistant professor of neurology at the medical school. He comes to us from having received his medical degree at the prestigious All India Institute of Medical Sciences. He did his neurology training at the University of Kentucky and also at Brown, and did a fellowship in neuro-oncology at Beth Israel Deaconess and Harvard Medical School. So he's going to be talking to us today about his project on outcomes for elderly patients with glioblastoma and how can we do better. So take it away, and thank you for being here today.
Thank you, Dr. Rounds, for the kind introduction. I appreciate everyone listening. So I think this is sort of a area similar to essential tremor, essentially that we don't often talk about with glioblastoma, and that is the focus of our project. So as part of my disclosures, we have institutional funding for a clinical trial from 4Biotherapeutics that I serve as the PI for. I don't receive any personal compensation for that. I'm not going to discuss any products from 4Biotherapeutics. and additionally, the support from the Advanced CTR Pilot Award, which we definitely appreciate. So glioblastoma is primarily a disease of elderly patients, and this is something I think is widely understood, but still perhaps not something which we focus on in terms of research. So glioblastoma, because this is a mixed audience, I'm going to talk about some basic aspects of glioblastoma care. We will be talking a little bit about aspects outside the project to begin with. So I consider it to be the most common primary malignant brain tumor. The statistics are collected in slightly weird ways for brain tumors, but most people agree that it represents more than 50% of malignant brain tumors in the United States. A lot of the data has been taken from the Central Brain Tumor Registry of the United States, which represents an NIH and National Cancer Institute effort to collect data regarding brain tumors. So the median age of diagnosis of glioblastoma continues to slowly increase over time. Whenever the CB Trust and the NCI look at their data over these 4-year blocks that they typically do, the median age of diagnosis typically increases by 2 years. And that reflects the aging of the population primarily over any other factor, in my opinion. The incidence of glioblastoma is 3 times higher in the age group of 65 plus, which would be typically considered the older patient subset in any neoplastic disease in oncology. So looking here at this graph, which I've taken from a CB Trust, most recent CB Trust report, these reports usually run a few years behind of actual time. So this is the most recent one from 2024. And we can see here as a reference point for 40 to 64-year-old patients, we can see that there is a significant difference in the incidence rate. This is age-adjusted incidence rate. So in spite of that, there is a substantial increase in the risk of glioblastoma in a 65-plus year patient population. Unfortunately, clinical trials currently, particularly therapeutic clinical trials, ignore these patient populations, and clinical trials, by their very demanding nature for travel, therapeutics, increased frequency of visits, often enroll a much younger patient population than this 65 plus year patient population. So I did want to include a national distribution from the central cancer registries of the United States. I included primarily because there is this impression that Rhode Island has a very high incidence of glioblastoma. I think that might be a little bit of a referral bias because Rhode Island only has a single institution to provide care to glioblastoma. As you can see from the color coding of incidence here, primarily I think we are seeing an age-related differential, even though this is age-adjusted. And Rhode Island is not unique among the color coding. There are several states which have similar rates of glioblastoma. And as the country ages, the incidence rate potentially will slowly rise. So in terms of current care for glioblastoma, outcomes have slowly improved. They have improved incrementally rather than in big steps as we would prefer. But overall survival continues to move forward over time. Currently, I think most people would agree that approximately 25% of patients have a 2-year survival, and approximately 5 to 10% of patients, depending on the data set which is looked at, have a 5-year survival. Ultimately, the goal is that the 5-year survival time point just needs much more patients. So the advances which have happened over the last 20 years include the FDA approval of temozolomide, which was a relatively significant change in 2005. Bevacizumab for recurrent disease, which is a vascular endothelial growth factor inhibitor in 2009. The Optune device, which is a completely unique electromagnetic device, which has been validated for glioblastoma several times in several studies now. First for recurrent disease in 2011, and then as a first line option in 2015. And all of these have improved survival as is validated over these longitudinal patient registries outside of clinical trials as well. So when we talk about first line treatment for glioblastoma, the first step is typically maximum safe resection as feasible. The feasible portion is an important thing here. Not all brain tumors can be maximally resected without causing devastating neurological problems. So ultimately, safe resection, maximally possible, is the way to go. However, it does appear that the more you resect, even among these patients, the better patients do. These trials can be very difficult to do. So there are some limitations to these trials because sometimes you can't resect more because of the location of the study. So a truly randomized, bias-free study in this area is very challenging to do. But some studies which have attempted to stratify patients and try to truly randomize patients, which is really not feasible, but it does appear that there is a difference which can be shown even in larger data sets of removing greater than 70%. The number is argued upon, it depends on the data set, but most people agree that larger resections are beneficial. Post-resection, first-line treatment in today's day and age consists of concurrent therapy with temozolomide, which is our first-line chemotherapy, oral chemotherapy agent combined with radiation therapy. This is typically done for 6 weeks, which is followed by multiple intermittent cycles of oral chemotherapy with temozolomide. And this was the pivotal study which led to temozolomide approval. And we can see a significant difference between radiation therapy administered by itself and radiation therapy plus temozolomide. So this is a very important and unique aspect to glioblastoma, which is something we often talk about as making a big difference for patient outcomes. So MGMT promoter methylation, as a reminder for people not well versed in this area, is a methylation of a gene promoter, essentially turns off the gene, leading to reduced expression. So MGMT promoter methylation shuts off MGMT, and methylguanine methyltransferase is a vital DNA repair pathway, particularly as it pertains to DNA repair in response to chemotherapy agents. So in this study from 2005, which looked at the temozolomide approval study and stratified patients by methylated and unmethylated status, there is a significant improvement in outcome. This is an outcome as measured by overall survival over time. There's a significant improvement which is seen in methylated patients. The median overall survival was approximately doubled when MGMT was methylated. So this does have a pretty significant and probably a very profound impact on how patients can do better. So now coming on to the focus of our study and data relevant to that, there is some data for older patients. Older patient specific studies are uncommon. Typically, they are not supported by industry, which sort of reduces that number. These trials have typically been supported by national healthcare agencies. So this data that I'm quoting here is one of the most common approaches, I would say, for treating older patients. Essentially, it's a reduction of the course of radiation from a total of 6 weeks to a total of 3 weeks, with a reduction in total dose administered. Radiation has been felt to be the most toxic therapy for older patients, and this is an effort to reduce that toxicity. So this study was supported by the Canadian Clinical Trial Group, which is supported by the Canadian federal government as well as the European countries as well. And they managed to incorporate a sizable number of greater than 65-year-old patients in this truly randomized study, which randomized patients between radiation alone and radiation plus temozolomide. So we do see that there is still a difference with a combination therapy, with the reduction of side effects by reducing the duration of radiation. However, this difference is not as profound as what was seen previously on the previous curve, which was for all comers regardless of age. Median overall survival was close to 9.3 months. And I'm going to convert this to days because the data I'm going to present from our study is from 200, is based on days. So 9.3 months essentially converts to approximately 280 days. So while these numbers obviously are not as good as conventional clinical trials in this situation, this is entirely a different patient population. So the expectation in an older patient population would be that these numbers would certainly look inferior than all comers. So talking about our study, our main hypothesis and clinical question was that we have options for selecting patients for reduced intensity of therapy. But numerical age has been acknowledged in other studies previously that a 65-year-old, all 65-year-olds are not the same. And this is a important point for oncology, but potentially for other areas of medical practice as well, that all older patients are not a homogeneous group, and age is a poor surrogate to solve for that. The way I think about using age to select patients for reduced intensity therapy is that it might be a good numerical surrogate, but it needs to be interpreted in context. And ultimately, the goal is how do you balance effective therapy with maintaining quality of life? And how best to select older patients. We certainly do not think of age as being a very good alternative surrogate marker. We use it because that's kind of what we have. So our hypothesis was primarily based on the fact that there are patient-specific factors which are pre-existing, and our focus was on the ApoE4 carrier genotype. And Dr. Alhusaini already mentioned the ApoE4 carrier genotype status as providing a risk for Alzheimer's, and we will talk a little bit about that. And our hypothesis was that ApoE4 clinical factors, neuropathological changes, all potentially are drivers of acute toxicity post-initial therapy. And in our experience, this acute toxicity post-initial therapy initiation is a big driver of patients who have poor outcomes, particularly in this older age group of patients. So a little bit more about ApoE4. To the best of my understanding, there is not a firm grasp of why exactly it leads to a development of Alzheimer's disease. This is a risk factor. This is not a cause of Alzheimer's disease. A good example for people who are less used to looking at clinical risk factors is that smoking is a risk factor for lung cancer, but all smokers do not develop lung cancer. In fact, a sizable number of smokers do not develop lung cancer. Dr. Alhusaini was referring to a risk of approximately 8 to 10 times above baseline. He was referring to ApoE4 homozygous status, where you have two alleles or two copies of ApoE4. But even a single copy of ApoE4 does increase your disease risk approximately 3 to 4 times above baseline. ApoE4 homozygosity does exist in the population, but it's less common. So our focus in this study is on heterozygosity. So our ApoE4 data is not fully mature, so we are still in the process of collecting that data. So some of the primary data which we are going to be presenting today as part of this study would be a novel score which we have tried to design for elderly patients to try to incorporate clinical factors, particularly to be validated as a poor outcome measure, particularly as it pertains to retrospective assessment of quality of life. So the focus is on assessment of existing known factors to create a database. Creating this database will also create a long-standing resource which can be used for this project and future projects to answer questions regarding this patient population, which is an understudied patient population systematically. The acute toxicity of initial first-line therapy in the first 16 weeks was really a focus of our score. So this is a score which we have tried to generate based on acute toxicity observed in these patients in the first 16 weeks following treatment initiation. And we will talk more about this score when I present the data. In the interest of time, I wanted to go straight into the data because I think we will talk about the exact nature of the score when we present the data regarding it. So I have tried to present the data, the primary outcome as being as a reflection of median overall survival. For people who are not familiar with Kaplan-Meier curves, essentially each death is an event which we try to capture. And our current interim analysis that I'm going to be presenting captures about 3 years of data. Our overall goal with this project is to eventually accrue approximately 10 years of data. These are all retrospective patients. So our ability to capture all parameters can be limited by the retrospective nature of the study. And we hope that this will provide us ideas for future prospective studies. So when we segment, so all the patients are over 65, but we have subdivided them into two specific subgroups of somewhat older patients with age less than 75, and significantly older patients who are at least 75 or older. So this, though there appears that the curves appear to separate slightly, that in the nature of our interim data, this is currently not statistically significant. So I do expect that as our data matures with more data points, that I do expect that the age greater than 75 patients will likely have poor outcomes, because age does play an influence in outcomes. We have noticed a trend already emerging that a lot of patients who are more than 75 often are not incorporated in the records, not because they don't have the diagnosis, but often because these records are being extracted from the neuro-oncology clinic, and these patients just are never clearly diagnosed because of significant problems with the tumor to begin with, or it's because patients and families of advanced age often elect not to pursue diagnostics or treatment. So that is certainly a limitation of the retrospective nature of this data, that those very older patients who don't pursue diagnostics or treatment would not be captured. So as a reflection of functional level, a little bit about the Karnofsky performance status, which we typically use in brain tumors to reflect the performance scale of the patient. We dichotomized our patients into a KPS of less than equal to 70 or greater than 70. We chose the point of 70 because this is commonly accepted as a point where people are relatively independent. So the expectation of people who are less than 70 or at 70 is that they're certainly needing some or a lot of assistance. We also did notice a trend emerging that people with very poor KPS scores also are not being seen. And I suspect that that is again reflects the retrospective nature, that these patients essentially forgo diagnostics itself. A technical definition of 70 as has been defined is an inability to work, patients who are still able to live at home and care for most personal needs, though they do need some assistance. These patients are not able to do active work or carry normal activities. So we failed to demonstrate in the current status of our data that a KPS difference did not really reflect a change in outcome. These curves are essentially not statistically significantly different from each other. So moving on to the MGMT methylation status, I already presented some data about the MGMT methylation status in all patients. So this is widely reflected as a very strong factor in outcomes. We currently are not seeing a statistically significant difference, but I do think that we are beginning to see a difference emerging. And I suspect that as the data matures, that this will be statistically significant. The MGMT methylation, which is the positive factor for survival, we can clearly see a significant tail emerging on the survival curves, while the unmethylated patients have a more steep drop off. I will highlight something in this curve which sort of indicates treatment related problems. I think this acute decline in the initial period, regardless of MGMT status, is not something we see in younger age groups of patients, including the data I previously presented. And I do think that this drop off initially reflects treatment toxicity, not treatment effect. And that might be why the curves subsequently separate, because treatment is actually effective. It's just the patient tolerability of it is what drives some of these issues. And again, as a reminder, methylated patients have improved survival typically based on an enhanced sensitivity to chemotherapy, based on a direct interference of how the cancer cells repair themselves from chemotherapy damage. So continuing on to our score that we designed for this is a composite primary outcome of early treatment toxicity over the initial 16 weeks. This is not a validated score. This is a score we designed, and our study is going to validate this score and how it reflects toxicity, but how it reflects overall survival as well. So these are the 4 factors we specifically looked at. So any hospital admission during the first 16 weeks, breakthrough seizures which require the use of more than one additional anti-seizure medication. One anti-seizure medication is not adequate. The loss, if a patient is previously independently ambulatory, did they lose that ambulatory status within 16 weeks of treatment initiation? and an increase in steroid dose by significant numbers. Steroids are typically used to manage physical symptoms. So we wanted to capture this as something which might be preventing a patient from being admitted or having physical decline. So when we dichotomize this composite outcome to a score of at least 2 or more to less than 2, which really reflects a score of 0 or 1. So it's 0 or 1 versus 2 or more. We did find a very significant difference in overall survival. This is not surprising, but while this is not surprising, any novel score which is designed does need to be validated, and we have been successful in showing a pretty significant difference in overall survival. The numbers, unfortunately, for these patients who have a higher score is quite low at 120 days, which essentially reflects a pretty dire prognosis for some of these patients. So looking at other factors that we have also assessed for our future multivariate analysis and stuff which did show significance. Surgical procedures did show significance for us. This is not something which there is a lot of pre-existing clinical trial data. There is some retrospective data, and we hope to add more data to this based on the differences that we are already seeing. So gross total resection of the tumor does appear to provide benefit in comparison to subtotal resection and biopsy, which we pooled together. As leftover tumor and biopsy is difficult to separate clinically in these patients. So moving on to, so we are continuing with the study. This represents what I just presented, represents approximately 6 months of data collection. So we are continuing forward with the study, and currently we are subjecting retrospective samples, which we already have access to tissue and biomarker assessments. So the tissue assessments are primarily going to be geared towards looking at incipient changes in the normal brain surrounding the tumor of vascular changes as well as changes indicating neuronal loss, indicating a pre-existing risk for cognitive issues. In terms of biomarkers, we are performing phospho-tau 217 single plexes, glial fibrillary acidic protein, neurofilament light chain, brain-derived tau, and USH1 multiplex studies. These biomarkers have been associated in neurodegenerative studies. There is very little data for them as it pertains to brain tumors and outcomes, and our goal is ultimately to obtain these plasma samples from initial untreated patients to see how their pre-existing factors and how they play into the poor outcomes in these patients. We have had some problems with ApoE genotyping with retrospective blood samples based on storage. So we are currently planning on using the tissue samples for ApoE genotyping. So ultimately, we have tried to invert a common way in which oncology functions. A common way of oncology and molecular testing or biomarker testing is we identify a biomarker or we use that to improve treatments. We essentially want to identify the opposite biomarker, a biomarker which identifies patients who do worse, and essentially to try to improve treatment for them, particularly as it pertains to acute toxicity. Because while treating elderly patients and improving outcomes is important, ultimately early treatment toxicity leads to poor outcomes, and designing treatment regimens which reduce toxicity might actually improve outcomes by sort of making the patient tolerate more treatment. Because these patients can have sensitive disease, but sensitive disease can only be treated if you can actually tolerate the treatment. So I think of it as poor outcomes as being a central figure in several factors, the patient-specific pre-existing factors such as a risk of cognitive impairment, the treatment regimen which is chosen and how aggressive that treatment regimen is. And unfortunately, there is a factor which I don't think can be fundamentally altered, that elderly patients are susceptible to increased toxicity. And I don't necessarily consider this a modifiable factor. I think our focus is going to be on patient-specific pre-existing factors and designing new regimens. And we look forward to continuing this work and reporting on our data. Thank you for the time. Um, the organizers also wanted to make an announcement for the next upcoming session on February 12th.
Great. Thank you very, very much. This was very interesting and provocative as well. Um, so I have would like to ask in people over the age of 65, they're likely to have other significant comorbidities, heart disease, lung disease, toxic exposures. Has the epidemiologic data been adjusted to account for comorbidities? And
So it is difficult for us in a retrospective study to capture all comorbidities, but
yeah,
I do think that in prospective data collection, which would be the next step from this study, we will have to adjust for those factors. The general thinking in the field is, and we use this for prospective clinical trials for intervention, is that it is very difficult to balance comorbidities. For instance, people can have a heart attack and recover completely from it, and someone can have a heart attack and develop significant problems from it, including heart failure,
mhm.
more physical disability, and fundamentally, that is difficult to measure. And without a measurable way of dividing those patients, I think the thinking for prospective studies has been that functional level is often used as a surrogate. The thinking is that if you had a very significant comorbidity, it would impact your functional level, and your functional level will be a driver of poor outcomes. I hope that makes sense.
Yeah. What about the Carlson comorbidity index? Does that help at all?
I am not familiar with its application. There are new emerging geriatric scales which are
Right.
being used in oncology.
Frailty is another one. Yeah.
Yes, so some of those geriatric scales are certainly being increasingly applied. I am not familiar with the comorbidity index, but some of the geriatric scales do include comorbidities as well. Geriatric oncology is sort of a area in evolution, so I certainly think that we need better ways of measuring comorbidities. And certainly, many of these patients, it's very likely that early toxicity is being driven by comorbidities. And the focus of our study is essentially a comorbidity and alteration in pre-existing risk for cognitive risk factors is an undiagnosed comorbidity.
Oh, well, it sounds like there's a lot of really interesting, both clinical as well as epidemiology questions to be answered in this field. Um, so I want to thank you very, very much, both of our speakers today. These were very interesting talks and interesting areas, raised lots of new questions, and we'll look forward to seeing more interesting results coming from both of you. And thank you once again for your time. And have a great day and happy holidays to everybody.